Okay, I bet everyone had a great day out skiing. It's been fantastic weather. Please take your seats, sit up front. Also, I need to remind people it's a very relaxed and familiar like setting, but please stay quiet during the talks and don't wander too much in the back or do small talk. We'll do lots of that afterwards. Also, the brochure passed out by Paula Borgenio. She's kind of waiting for some of those to come back, so please go through them and fill them out. Won't take you long. All right, people in the back in the coffee machine, get seated. So for this evening's session, it's going to be most about ECMO, but we'll also finish up with resuscitation more in general by Tim Harris. But first up is an ECMO session. We'll have 3 talks taking you through pre-hospital ECMO, ED ECMO, and in intensive care. Then we'll have a break. We'll talk about ECMO for trauma patients. Sounds like a really bad idea, but it might turn out that it's a good idea. You'll find out. And then a bit about good resuscitation by Tim Harris. And Ollie has a few words. I think he has a credit card. How much did you spend?
Yeah, good news, bad news. Before someone cancels his credit card, we have it. Marius Clausen. Is this yours? All right.
He's paying for the fondue. Okay, first up is someone I'm really looking forward to hearing from, Lionel Lamour, who's doing ECMO work, but also pre-hospital ECMO work for pre-hospital ECMO for cardiac arrests in Paris. So I'm looking forward to, you've done that for some years, and I'm looking forward to what you have to tell us about your experiences there. Thank you.
Thank you for the invitation. It was a pleasure to be here. And this is the first Congress. It's not working.
Yeah.
So you try this one instead?
Yeah, just swap to that. Yeah, isn't it?
No. Okay. It's a striptease.
Now we're ready. Okay, go, Lionel
It's
Lamour.
good.
Not hearing you now.
It's not working with me. Good. 1, 2, 1, 2. You listen me or not? It's working? Okay, go. We start. Thank you for this invitation. I will be there. And this is the first invitation without any title on the programs. I decide to do what I would like to do today. Just like we said this morning, we need to know where we are. It's very important to have a register, because when we implement new techniques, we have to know where we are. We implement ECPR in pre-hospital in 2011 at this year, and this is the first step why we start ECPR, is because we have for Paris and sub-area 3,000 sudden deaths and just 139 survivors discharged to the hospital, CPC 1 or 2. That means this is a disaster at this time. And we do a lot of things to increase the survival rate, is discussed this morning. At this time, for the major part of cardiac arrest, where we have no risk, and this is the major part of cardiac arrest, depending what happens, the no flow, the low flow circumstances, we decide not heart beating donation or didn't sin. But this is old school. And we need to advance. Why? Because we misunderstanding something in cardiac arrest. Cardiac arrest is just a sign. And in the same disease, we have 2 diseases. First of all, the heart. Major part are STEMI patients. And what we're doing when we have a cardiac arrest, we have just one goal, ROSC. But we forget something, the brain. And the brain is a second step, and this is a prognosis for the long term. And probably during the first 20 minutes, we have to be concentrated to do everything in the battle to have a ROSC, CPR good quality, shock, everything what we want. But after these 20 minutes, with hypoxia, acidosis, and everything, we are in metabolic phase. Probably we have to concentrate to the brain. We change the paradigm. And because we can do that now, because we have something can replace the heart, is ECMO. Okay? This is why we change the mind for cardiac arrest at this time. And this is why we start this program. In the same period, 2008, Chen, you know this paper very well, cardiac arrest, in-hospital cardiac arrest. They do ECPR, a lot of survival compared to the no ECPR. And what we're doing at this time, we take all out-hospital cardiac arrest, we go to the hospital and we go in ECPR, and we are very disappointed. 4% of survival in 2011. I said, whoa. And we go in Congress, and this hospital team in Paris presents the result and said, we have to stop. Too much money, too much time. For what? Just 2 patients survive. Why? And I said, uh-oh, guys. The goal of the SAMU, of mobile ICU, is to take the hospital at home. Why we don't take the ECPR at home? They said, you are completely crazy. I said, yes, we do. This is why we need to do something. It's not easy, we know that, but if we think the problem is the time, we have to advance. And what we're doing, to know why it doesn't work, we think about where, when, how we have to implement ECMO, ECPR. First of all, how? We start by percutaneous. This is a paper of Zach. They do in percutaneous in San Diego. You probably talk about this paper, but it looks like be easier. It's well known. We do every day, central line and everything. But during cardiac arrest, it's not so easy. The flow is very low. You can use ultrasound, but sometimes you see nothing, really nothing. And when you poke one time is good, but so a lot of time when you do in percutaneous, you have to poke a lot of time. And after, don't forget, you need some heparin and everything. You have a large hematoma. And in ICU, we have some patients die with this hematoma. And the problem of the repair of the legs when you are in percutaneous is complex. We start by these techniques, to be honest. And we have some difficulty. And so one day, with my friend Kim, we start this program together. We don't know this book, it's the Rouvière. It's the anatomy book in France, in medical school. Each student knows each page at the first years. And we come back the morning and we said, see, we have the same idea at the same time. That's funny. We see this part, and we said, why we don't do the same? Why don't open the scarpa? This looks like easy. And we go to do the cut down techniques. The cut down techniques is not the same as the surgeon. Surgeons are upper. We are in the scarpa but lower. We just open just to check where are the vessel. We can check the artery very easy, and the venous. It takes 3 minutes, not more, 5 minutes. It's really easy. And after we do what we know very well, sending our techniques. And in the same time, we can do the repair of the leg. At the end, the patient has this type of insertion. If we compare the different techniques, surgical, percutaneous, and mixed, first of all, for surgical, for pre-hospital, if you call a surgeon, you said, you have 2 minutes to go in my car because we have cardiac arrest. I don't know you, but me, you love. He said, it's not possible to come. You have some OR, you have something to do. You need a lot of material, a lot of time, because they are the job is in OR, they have a lot of material. When we work in pre-hospital every day, we are trained to work with less material. We are a small team. Everybody know where is the material. When we ask to a surgeon where is something, he said, I don't know. Ask to someone, a nurse or someone. The mixed techniques and the percutaneous is really available, and I think these two techniques are the best for intensivist and ER doctor. When we have to implement. The first question is the limit. Two large papers. The first one is Chen in 2008. It's an old one. We have a complete correlation during the CPR duration and the survival rate. And if you see after 60 minutes, we decrease a lot. And in the paper I show you from Paris, the major part of the patient here. That means 5%. That's the number we find. We need to go shortly in ECPR. And probably we have, like for trauma, the golden hour, for ECPR is exactly the same. We need to be in 60 minutes on pump. It's really short, in fact. It's a real deal every day. But if we need to be in 60 minutes, when can I start to think about ECPR? Because I don't want to take the morbidity of the ECMO if my patient can have a ROSC and survive in ICU with his own ROSC. This is a deal, in fact. And we are a little bit in the black box a few years ago. But check, large register, US register, check the title. When should we change to novel therapy? They do this paper just for that. This is the goal of the paper. What they show, after 16 minutes of CPR with EAD, less than 1% leaves the hospital with a good neurologic prognosis. Short, 16 minutes. It's confirmed by other study. This is a Korean group, I think, if I remember. 21 minutes, this is the best way to be on ECPR. And if you check, this is the same team, check on the group without any CPR, group with ECPR, the important is the black box, CPC 1 or 2 at 3 months. That's the goal, not just ROSC or something else. That's neurologic stature, the major point. You see on classical CPR, after 21 minutes, just few, and after 40 minutes, nobody. And on the group of ECPR, you have some survivor. We can think reasonably 20 minutes, it's a good time to switch to ECPR if the classical CPR is failed. And classical CPR today is CPR, chest compression, AED, ventilation, epinephrine, amiodarone, have no show any difference in survival. Where? When we check on register, the first one is Vienna. It's likely Paris. They have mobile ICU, old town, a lot of traffic. They check 1 hour to take the patient to go to the hospital. Okay, some of you or everybody said, okay, this is because you have a doctor inside, you lose some time. Okay, check. Paramedics team, same time in Asia. Why? Because in city, it's not so easy to go to hospital. In this picture, we are in the flat of a patient go in cardiac arrest. Here, in the same street, we have an hospital with ECPR center. But to reach this hospital, what you have to do? It's not 20 minutes. It's more time. Because in the city, it's not the distance the problem. We have one vertical limit and one horizontal limit. It's really a big deal to do that. And when you have a system where the level of care of your mobile ICU is the same of in-hospital, why we don't do in pre-hospital ECPR? What is the difference? It's just logistic. This is why we do a first study to compare pre-hospital and in-hospital eCPR, safety and feasibility, few patients at this time. To skip this red bar is the transportation time. And you see we decrease really the time to go in pump. We are able to do everywhere. Everywhere. Road, subway, supermarket. They doesn't close the supermarket. The Louvre. They close the Louvre. Radeau de la Méduse. Le peuple guidant la liberté. Sorry, we work in Paris. But it's not just the alone solution. We can go in hospital if your system is organized to do that. Probably Zach discussed this story of Yiannopoulos in Minneapolis. Just check, 72 patients go in cath lab, just 47 have the CPR, and they have good results. But if you go in Minneapolis, you check the city, it's really not what you have in Europe. Really not. On each road, you have some system. When you see an ambulance, everything is green and everything is, the traffic is not the same. Because when we do the same in France, in another city, Nancy, they try to do a protocol. 15 minutes on scene, 15 minutes to transfer, everything. They reduce the time with the protocol to transfer to hospital, but they stay very high, 80 minutes to be on pump. We are not in 60 minutes. Because, I repeat, when you are here on the back floor, you have to take this stair. It's not easy to go to hospital on all this situation. The transportation time is a long time. The patient is here. But no stress. During an ECMO, this is my driver. What he doing? He read something. We do a training program, and this is a key point of that. This is a large training program with everybody on pre-hospital, firefighter basic life support, mobile ICU, ECMO team, in-hospital ICU, in-hospital surgeon. Everybody on the same table are agree. And they are agreed to start this program with a large training. We do cadaver, we do simulation, high fidelity simulation, and everything to try to have the best level. And the other advantage of pre-hospital ECMO is for patients very far. For example, this patient is here from Paris. By road is 1.5 hours with the traffic, something else. Before, this patient was dead on scene, for sure. No center take care of this patient because it's too far. He said, no, it's not in time. And now what we can do, we go directly with the helicopter on scene, and we insert the eCPR on scene. It will be far. For this patient, no flow was null. Alert takeoff 18 minutes. It's long because the helicopter is not in the same hospital of us. Alert pump 50 minutes. Low flow 83. 83 is not 60, but for a patient so far, it's nice. And he survived. For this type of patient, outside Paris or far, we have today 10% of survivors CPC 1 or 2, and before all are dead. The last point is to select patients. This is the old selection in France we have. It's old. Don't take picture of that. Just why is old as is not very accurate for us. Check. The best way for choose is a no flow. But the no flow, we know is a better prognosis factor. Everybody is okay for that. But nobody knows the no flow in pre-hospital system. When we asked to the family, what is the no flow? Each family said, no, no flow, 0. And when we are in ICU, you ask the question, what is the no flow? What do you call no flow first? And after when we ask, when you start the CPR? I listen a noise, I'm going off, I don't know what happening, I call my husband, and he said to call the 911 and everything. And at the end, we said it's 10 minutes. 10 minutes for people is nothing, but for brain, it's finished. And take patient in eCPR just for the no flow is really not a good thing. This is why we check on the patient what's happening, and first of all we find asystole with no sign of life. Sign of life is pupil reactivity, movement, breath, gasp. If you have asystole and no sign of life, your patient is dead. No ECPR. And this is a major part of the patients we have in cardiac arrest. And that means we can select patients with this type of things. This is why it's very important to have some register. Because if you have no register, you cannot check this point, for example. This is the algorithm we do today. We can take the photo now. I help. When we have a refractory cardiac arrest, we define refractory cardiac arrest 20 minutes of CPR with AED. Sign of life. Hypothermia less than 32. Intoxication or general anesthesia. You go in ECPR. No more discussion. And you have no deal with time for these criteria. Because if the patient coming 2 hours after, but he continue to move, that means the brain is alive. You can't go in CPR. After it's more complex. If you have no major comorbidity, witness cardiac arrest, immediate CPR, no flow less than 5 minutes. No flow less than 5 minutes, that means it's cardiac arrest with EMS. That means people see the patient fell over and start CPR immediately. If the initial rate is VF, VT of PEA, ATCO2 10, more than 10, and you are in pump in less than 60, acceptable 100 minutes, you can consider a CPR. For the patient, you continue the CPR, the AED, and CPR, and you check if you can do donation or classical advanced life support. And with a global strategy, we start a global strategy now in 2011. And we compare 2 periods. The first period is when we go on scene. We're waiting the mobile ICU, call us, said, okay, it's 10 minutes I'm on scene. You have no ROSC, can you come? During the second period, we go directly at the call. When we have a call now in Paris for witness cardiac arrest less than 65 years old, the ECMO team go on scene directly. It can be cancelled before, but they are alert immediately. We stop the epinephrine at 5 milligrams, and we go to angiography systematically. What we see, we reduce the time, for sure, between the 2 periods. And in the same period, 1 and 2, you see on pre-hospital, we decrease a lot. And the time of insertion decrease in pre-hospital more than in hospital, because in pre-hospital we are a small team, very trained small team. But this is a global strategy, and it's very important after to go to angio. What we found is very interesting, because at the start we think it's the same cardiac arrest than other cardiac arrest. In fact, no. When we check the lesion of coronary, we have multiple lesions, a lot of multiple lesions. And what is very interesting, they are very proximal. This is why the patient cannot have a ROSC, because it's completely blocked. It's not just a rhythm, a problem of rhythm. And with this strategy, when we check the survival rate, because this is a major point now, if we have not the new selection, we keep the old selection. And we have not the protocol. The protocol is pre-hospital ECPR, epinephrine less than 5, and angio. You have nothing of that, and not the good selection, 3% of survival. When you select correctly the patient, but you don't do all the protocol, you have in-hospital ECPR, for example, 90% of survival. And when you have the selection and the protocol, 38% of survival, CPC 1 or 2, at the discharge of ICU. Remember, these patients all are dead before. We have no ROSC at this time. This is why now we in hospital cardiac arrest. Today it's 48 patients. We're opening other center shortly. And just for your center, today in the guideline, ECPR is one part. And I think today in the large city, it's not possible to invent any program of ECPR, in, out, whatever. But it's incredible to not have a ECPR program because it saves life. And if we see the force of the ECPR, save life, give a new hope. Have you a new program can increase so much the mortality, survival. Increase the quality of care for sure, because when you do that, we train everybody. We have a second car come in place. The care have increased for sure. And we don't discuss here because it's not the topic, but a part of the patient, after we go in CPR to treat the patient, but some patients unfortunately go in brain death. We do some donation. It's 30% of the patient. The dark side is the cost, the resources, and we can discuss the vegetative statue. In France, we haven't really few, and 200 we have just 2, because we can limit the care if you would like. The take-home message, ECPR save life. We need to start 20 minutes after the start of the CPR with AED. The goal is to be in 60 minutes on pump. You can prolong this time if you have no protection or sign of life for your patient. How? Select your patient. If you don't select your patient, you crash the technique. For sure, after 2 months, everybody would like to stop because you have no survivor. The technique you use, you choose. Me experience, you use what you know better. Pre-hospital ECPR need to be confirmed by the RCT, but it looks like to be very interesting. I don't know if for all patients, but to be honest, for sure for some patients, because they are never in 60 minutes to the hospital when you are at the last floor or something else. And I think now we can add a new link. The ECMO team, I think it's really important. Thanks to my team. And we have sometimes some special guests. Paul is not here, but he's coming. James or everybody can come in. Thank you for your attention.
I mean, you can never watch too many ECMO videos, right? I mean, we'll just watch this over and over again. We're all good? Yeah? Hear me in the back? All right, cool. Well, what a conference, Thomas. Strong work. I mean, seriously, it's a joy to be here. I have come from San Diego. Let's hope this works too. And I am very thankful for one thing, and that is that you chose English as the language to speak. If this was in German, it would not be nearly as good of a presentation by me. In fact, I speak, I speak 2 languages, English and Spanglish, which means I speak just enough Spanish to meet the inclusion criteria for ECMO patients when they come in the door. Other than that, it's done. I did notice, though, on all the signs around here that most of them, you have German and French and Italian, and the last one would be English, except for one sign up on the slopes, and that was slow. in English first. So I don't know. You can make your own inferences on what that means about the people that speak English. But yeah, so I'm an emergency physician from San Diego, California. I am our vice chair of emergency medicine. I wear a couple of different hats, but my joy in life is I love to work. I actually love working shifts in the ER. I love resuscitating people. And out of that has born this very fortunate series of events that happened to us where we started doing eCPR in our hospital. We did it a little bit backwards. It started with a patient. We didn't really ask for permission. We kind of just set up the program and made a few relationships, and a very fortunate patient came in, a 59-year-old guy, out of hospital cardiac arrest, STEMI on his EKG, and he came in and we did nearly everything possibly wrong that we could do on that first patient. But somehow after 59 minutes we got him on the pump. He made it up. He got, his resuscitation was adequate, and I called our cardiologist to come in. He walked into the ER and he said, "You did what? You put somebody on ECMO?" And he then proceeded to drive home. Our patient got admitted to the ICU. He woke up a couple hours later. It was an expensive stay. He woke up a couple hours later. The cardiologist came back in, stented the patient, and Ralph Berry has been our poster child ever since. So we had a series of events that were fortuitous for us, and out of this, a lot of things happened. We started doing this more frequently, and we've had some data that we've shown where in our hospital, when you compare patients that get ECMO and you don't get ECMO, you're almost 10 times more likely to survive. Clearly, there are problems with comparing patients here, apples to apples. I will say we're about to publish some more data, but one of the interesting things and one of the critiques that we get often is that we take up all these ICU beds, and they're in the hospital for forever. Well, in our patients, patients that stay for more than 1 day in the hospital, so if we put them on pump, we do this massive resuscitation. If they last more than 24 hours, more than two-thirds of those patients walk out of the hospital CPC 1 and 2. So these are incredibly high numbers. And so when we start coming to this, we realize that there are that eCPR can offer some significant advantages to our typical therapy, but how much? And that is one of the questions. Out of this, born a couple things. We talked about ED-ECMO. This has been a very great part of my career, doing podcasts and being able to interview a lot of different people here, including Magnus and Lionel, and then being more of like a voice for what this could be in the community, not just for in the ER, but also for upstairs and pre-hospital. Out of this was born a conference that we've started doing. We've done now 5 of them. Well, I'm sorry, we've done 4 of them. The 5th one is in a couple of weeks. And we've had some great success with training people from all over the world. We've had 200 some docs, 6 different continents, and each of those docs has gone on and started lots of different programs throughout the world. So it's been a fortuitous thing for us, and we've felt very lucky to be able to be a part of it. So today, what am I going to talk about? You've got ECMO Rama, right, this afternoon, and I'm going to just fulfill a very small niche in here. We've got trauma from Magnus. We've got Håkan is going to talk about more physiology. We've got pre-hospital for Lionel. And I'm going to focus on just a couple of high-level things and maybe give you some pointers in 2018. So we'll talk a little bit about the current state of ECMO. We'll talk a little bit about a couple of pearls, not just for ECMO, but for resuscitation in general. And then I'm going to conclude with a couple of challenges for you as resuscitationists on how we can actually change the future of medicine, not just from the standpoint of patients that are in front of us, but in light of what kind of technologies actually come and become a part of our practice. Okay, so Lionel showed you this. This was my day in Paris. We did 3 ECMO cases pre-hospital in 1 day. We did 5 different arrests. We were 18 hours without any food. And so weak. So weak. So I will never live that one down. I refused an ECMO patient. No, they didn't actually have any more that night, but still, amazing experiences are going on all around the world. And Lionel is one huge piece of this. But all around the world, eCPR is increasing. The numbers are increasing exponentially. We just have this consortium now with EDs in the US where we published with 26 different hospitals that are doing ED ECMO. There's actually a number more than this that was on this. Just from our courses alone, we know that different hospitals that we have trained. But the number of eCPR cases are going up and up and up. And so when we start thinking about ECMO, and we start thinking about how this technology exists right now, what phase are we in of this, I'm actually fairly proud to say that in the 6 or 7 years that I've been giving talks about ECMO, we've changed. When I used to give this talk in the US, 6 years ago, this whole concept of how does it work was the whole talk. Nobody knew this. We'd be putting in venous cannulas, sucking out some blood, pushing it retrograde up the aorta to perfuse the brain and the carotids. That just seems now like passé. We're beyond this first phase of technology, and I'm quite proud that we can now say we're into the second phase, and that is, does it work? And of course, this has been one of the questions that has plagued or has had great resistance in a lot of hospitals, because we don't have any randomized controlled trial that says ECMO is better than conventional resuscitation. We don't have any placebo group, and we probably won't have something like that in the near future. I will say that this last year, and this is a paper that probably got overlooked by many of you, but Josh Reynolds, I think, published something that had a great, can give us some really good ammo for our administration when we come home. Because we know ECMO patients, right, they have these prolonged arrests. Lionel just talked about 60 minutes of downtime, right? But we know that of those patients, even though they have these prolonged downtimes, they're the best of those patients, right? They're the patients that had witnessed arrest. They had no asystole. They got bystander CPR. They have a certain age. They don't have comorbidities. So when we take those patients, and this is what Josh Reynolds did in this graph right here, when we take those patients, we see what we already know, is that they still die. At 30 minutes, the mortality is still greater than 90%, probably greater than 95%. And so when we look at these numbers that we see all around the world, ELSO database showing 28% survival. Lionel, I think your most recent paper had 29% overall survival. Ours is very similar to that as well. These numbers need to be viewed in light of the expected survival in a patient that has 60 minutes of downtime. So when you get emails like I have gotten that said, Dr. Shiner, there is a procedure that you do in the ER that has a 70% mortality. We'd like you to come and talk to us about this procedure, ECMO. That you understand that there is actually a big difference between hospital administration, even some specialists, and their understanding of what you're doing. That the odds ratio of survival for these patients are very high when you start putting in these programs. All right, so in light of that, in light of these high numbers, these high success rates, we may think that we're on top of the mountain. And in some ways we are, and we start pushing the limits of this. We start saying, hey, maybe we can include PEA patients. At our hospital, we definitely include PEA patients. Yiannopoulos, who Lionel was talking about, and I'll mention some more, he does not use these patients because potentially they have worse outcomes. But PEA patients would be one of the discussions. The next discussion is whether we should have ECMO receiving centers. In San Diego right now, this is one of my main initiatives, is trying to train 4 different hospitals so that we can have 4 different places for cardiac arrest to go where they could get eCPR. This is primarily because of we need cooperation. We need county EMS systems to comply with what we think is the best thing for patients. And so ECMO receiver centers is the next thing. And then neuroprognostication, the idea that we need to have people give them a chance in the ICU. We can't say that 60 minutes of downtime and they're automatically dead. We need to realize that our ability to neuroprognosticate patients on ECMO is very limited. And so we push these envelopes, but we know that this is a fine balancing act. Even programs as strong as Lionel's, even programs like ours, where we just saved one of our hospital administrators about 2 months ago, that these are these are tenuous situations, and things go wrong, and you sometimes are thought of as the greatest thing on the planet, and the next day you are not. You are the cost problem. You are the specialty problem. You need to interact with CT surgeon and cardiologist, and so all these relationships continue to be important even after you've had successes upon successes upon successes. And finally, for us, and I know for many other programs, the politics come into play. Politics about different hospitals. In the U.S., of course, the money becomes a big deal. Are you stealing our cardiac arrest patients? Yes, we want to steal your cardiac arrest patients because we want to get 30% survival from them. So we know this is all a tenuous situation. And so in light of this, in light of these good things and these bad things, I want to talk to you about probably the most exciting thing when you talk about any technology, and that is, how do we do this better? How do we do this better? How do we do these things better? And when we start looking around the world, we know that there are three big dogs. The great one. Lionel's ability to transform a pre-hospital system, to even get that to even implement that is amazing. Sam's ability to implement EPR in Baltimore. These are huge things. Dimitri's ability to take patients directly from out-of-hospital cardiac arrest with a coordinated EMS system to the cath lab, where he has, like Lionel said, insertion times of 6 minutes. These are things that we need to look at and we need to be inspired by, and we need to see how we can implement their iterative changes into our system. The problem is that these systems, while in some cities can be mimicked, in many places they just can't. They just can't. There are not enough people like Lionel, like Sam, like Yiannopoulos to go around the world. We need people that are currently in the hospital, ready to manage cardiac arrest, and in the U.S., those are emergency physicians. Maybe in Norway, that's anesthesiologists, critical care docs, people that are there during the arrest that can help manage these patients. And so when we start thinking about that, we need to think of what we as resuscitationists, as the people who will be taking care of these front line, what do we need to develop? And my opinion is that the number one thing we need to focus on is an endovascular skill set. How many of you know this guy? Tiger Woods, the greatest golfer. And like any great athlete, he always picture that we all know him by to be a mugshot. Maybe you've seen this video. It's him screwing around with some of his friends. He took 3 takes to do this with a little homemade camera. And you realize the amount of time that Tiger has spent with a golf ball and a golf club, his deliberate practice, his 10,000 hours, if you follow Malcolm Gladwell. This idea to be able to hit a golf ball mid-air 200 yards is amazing, right? This is the same thing that we need to think about in our resuscitations. A skill set that we may have some skills in, but we could always get better. When we think about an intra-arrest femoral arterial line, that is what I'm talking about. These clamped down hypovolemic lines during chest compressions. Can we develop the skill set to be able to do this reliably and safely? For me, it wasn't enough to just do it on my shifts. I just didn't develop enough skills. And so for me, it actually involved going to my garage. And for our conferences, we made a lot of simulators. And just in making those simulators, I think I got a lot better at cannulating. I think for many of us, it can be spending time with our interventional radiologists, spending time with our interventional cardiologists. See what they do, see how to do it better. For us, it's also setting up labs where we can have our physicians go and just practice, practice, practice. Keep thinking about how to place these lines better. So cannulation pearls, there's just a few of them here. I'll say right now, ultrasound and wires, there was a paper just this month in resuscitation out of Paris where they said, hey, when we started using ultrasound and when we started using these Amplat super stiff wires, our success rates went up. I would agree. Things like micropuncture techniques. If you've used some of these really small needles that have ultrasound tips that you can see nicely under the ultrasound, less damage if you accidentally puncture the femoral artery and don't cannulate it. less complications, some little difficulties as far as how to manipulate the cannula, but I think there's some advantages to these. The Lucas, while we know that the data on mechanical chest compression devices is not great, there certainly is not overwhelming evidence saying that they are better than manual chest compressions. But for us, the advantage is that it allows for a smooth place for us to cannulate, a much more consistent way for us to be able to put these femoral artery cannulas in. And so we've actually used Lucas at our facility quite extensively. And then finally, the pelvis. Putting in lines on an ER bed or an ICU bed is about the worst possible place you could put them in. They're on soft beds. The pelvis sinks in. They have small amount of flexion of their hips. That is not the area that you want to put in a 19 French arterial cannula. Okay? So what do? I actually take the backboard that we don't use anymore for chest compressions, because we're utilizing Lucas, and instead of putting it in front of I put it right under their butt. Elevates up their hips, opens up their femoral groin, allows you to cannulate percutaneously for us, or cut down via Lionel in a much better fashion, especially when you start getting obesity in there, trying to get to those vessels. So those are just a couple of cannulation pearls. In addition to endovascular skill set, I would say the number 2 thing that I would say in 2018 is what we need to do is we need to organize. We need to organize well. For us, we have a specific place for each physician, for each nurse, for each tech in all of our resuscitations. You don't have to follow this one. This is what we've found to be the best for us, and I'm going to focus on 3 different people here. One of the things that we've done, which has been, I think, a big deal for us, is we've started to empower our nurses. We actually have nurses run the code. Because when we think about the metrics that we're interested in resuscitation, one of the biggest metrics that I'm interested in is minimizing interruptions. And guess who causes interruptions? You do. I do. Let me just take one more look with that ET tube. Give me just a second more to check for a pulse. We need someone outside that narrow mindset that can look and say, no, we're not going to do that. We need to be able to check for a pulse. We need to be able to check what their rhythm is. When are the medications need to be given? Someone who can cognitively offload the physician. And that brings into the alpha doc, who is the physician. And I'm actually going to rename him today the Richard Lyon doc. Because this is the guy that everything that Richard talked about earlier today, this is the guy that does that. We need one person that is in charge of, has no procedures they need to do. They have no responsibilities outside of getting the history, assessing from the medics, from the family, and then on patients that are newly arresting, maybe less so in patients that come in after 60 minutes of CPR, but newly arresting patients do not need ECMO. They need defibrillation if they're in VF, right? They need electricity. And so we need to make sure that the quality of our standard resuscitation is still kept high, even when we start implementing these new procedures like ECPR. The final person that I'll say here, and this has been a relatively recent thing for us, that we've developed an appreciation for the wire assistant, the person that holds the wire in the back. So when we put these cannulas in, we've got 160 centimeter, sometimes 260 centimeter wire that we're putting into the groin. It's flopping around in the back. You need somebody that knows what's going on. Dimitri in the cath lab has this advantage over all of us. He does this every single day with the same people, changing out cannulas. And so we've spent a lot of time training these hands right here. Push and pull. This one is racking the wire, as you can see, as it's going in, so it does not kink. With the super stiff wires, you have less of a complication with that. But they also have the ability to change out those wires, know the next dilator that you need, and know the final cannula that you need to put in. Training a wire assistant in an ECPR program for us has proven to be very beneficial. All right, so last component, last ideas here, and this is the future of resuscitation. Just, fortuitously, like I said, I have now been involved with a lot of the future technologies that are coming out, and with some of these companies that are trying to push the envelope on what we as resuscitationists do. And one of the things that I think we underappreciate, and I certainly underappreciated, was how much thinking goes into whether the physician would be willing to do the procedure. So when we talk about novel therapies, we talk about things that have never been done before, we need a physician to learn a new skill set. That's a huge risk to a company. I'm going to drop $100 million into making a device that the physicians have to learn a new technique. That's a big risk. And so one of the things as resuscitationists I think we need to do, as I just said, is that we need to start getting better and better at putting in these lines. For my critical patients, every single one of them has a femoral art line and a femoral venous line. 5 French art, 9 French femoral vein. And this allows better resuscitation. For cardiac arrest patients, it allows me to diagnose pseudo-PEA, allows me to assess the quality of the chest compressions, and it allows me to predict the rearrest that we so frequently see with these patients. So having art lines in, I think, is a big deal. For us, this has actually transitioned into a number of other procedures. So the Reboa catheter is now owned by the ER physician at Sharp Memorial, where we put these catheters in on trauma patients in assistance with the trauma surgeon at bedside doing other procedures. I work in a community hospital. I work in a place with no residents. We are physician poor, unlike most academic centers where you have way too many physicians, right? So we are in a place where we are constantly looking for ways that we can implement and do procedures better, and this is one of the ways that we've actually assisted the trauma surgeon. Another line, this is the Jim Manning that you saw from Lionel's talk, proximal aortic lines where we can titrate epinephrine at much smaller doses than we traditionally give. This is a potential advantage for us being able to cannulate the artery. And then other things, E-core, the idea that intubation is even, do we even need an ET tube for intubation? We can draw CO2 off on a COPD patient just fine with a catheter. What about an asthmatic? Should an asthmatic ever die? We are trying to correct a problem with an ET tube that's in the bronchioles. By putting a catheter in the neck, you could actually solve that problem quite quickly. And with advantages to new technologies, we can actually do this even better. I changed my mantra on this. After our first conference of Reanimate, I actually took out all the VV ECMO parts. I said, we're never doing this in the ER. And then a guy by the name of Conrad Soriano came into our ER, anaphylactic to peanuts. We intubated him. His pH after intubation was 6.7. He had a PCO2 of, I think, 140. And we were taking his ET tube off and literally sitting on his chest, trying to get him to exhale. We put a VV catheter in his neck. The problem was solved in a matter of hours. We took the catheter out. He walked home neurologically intact. These are the type of interventions that we could do with just a few vascular access pearls, benefits, skill set. The idea is not even there. As technology improves more and more, the procedures that you think are outrageous become simpler and simpler. Dimitri is able to get in the cath lab the whatever lesion it is that the patient has stented quite quickly. That potentially could be one of his beneficial aspects. If we could do that in the ER, I'm not talking about some circumflex little vessel, but putting a wire across an LAD, putting a wire across a right coronary, these are things that you can think about in the future once we start developing endovascular skill sets. All right, so today, take-home points, eCPR, great increase in numbers, supportive data. Secondaries, as far as pearls for you, I would encourage you to better at cannulation. Think about organization of your resuscitations, and then the future of medicine involves endovascular skill sets. Can we develop them? I certainly hope so. I will end with you on one story. This was a guy that came to one of our conferences, and he was an ER doc who had the unfortunate event of witnessing his own son's death. His son had a cardiac arrest right in front of him. He did chest compressions on him. He called the ambulance. Ambulance came. He rearrested. They brought him to the hospital, a little teeny hospital where he actually worked at, and he started managing his own son's PEA arrest in the ER. He eventually, with a CT surgeon physician assistant who had never done ECMO, he and this physician assistant put his son on ECMO, and his son is now neurologically intact and paramedic in Northern California. So these are the types of stories that just make you realize the power of some of these devices that we have and that are at our fingertips. Thank you.
good. Thank you for that, Shiner. Also, thank you for reminding us that those kind of devices. We certainly have the same sort of challenges at my hospital with yeah, but is it working? Oh, okay. I couldn't hear it here. We certainly have the same challenges in my hospital. The same discussions and resistance to initiating ECMO, so it's really interesting to hearing about the experiences of Zach Shiner. Now over to more familiar or closer geographical territory for me. From Sweden, there's a big ECMO center in Stockholm, and we have Håkan Karlsén, who's worked there for many years, works in the ECMO center. They have an ICU that only does ECMO, also does ECMO transports, and he'll go into ECMO physiology. Tell us a bit how all of this works.
LBLB.
Good. You're good to go.
Good. Thank you. Let's see the device to flip. It's there. Good. Hello, everybody. It's extremely nice to be here. I think you picked what a location. What a setup. Will it be back next year? We were speculating on, when you have the 10-year anniversary, we'll, make some sort of big, feel no pressure. I'm very happy to be invited, and I'm going to talk about a little about ECMO physiology and the transport system we have, because I'm fortunate enough to be an ECMO nerd who works at a sort of clear-cut, pure ECMO ICU. Can you think of a place like that, huh? And this is me in front of our air ambulance where we used to transport. And who am I? I got my medical training at the Karolinska Institute at Brown University. I became an anesthetist intensivist like you do in Sweden. And then did the European intensivist training program and went to London, to Royal Brompton to do PICU work. There, I got to see ECMO. It was bloody. There were no antibiotics. There were open chests. There was 70 to 80% mortality. It was really awful messy. And it felt like, ugh. So this is ECMO. So I went back home, continued to be an ICU physician, and Palle, my former boss, oh, you've been to England and you've been on ECMO, so come to my unit, And then I thought, like, more ECMO. This is just bloody mess. They'll all die. But then we run it in a better way. He had put together a unit there where it was success rates with the children around 90% survival and the adults 60, 70% survival. So suddenly I got hooked on it, and now I've been there for 11 years. And I've had like close to 100 transports with ECMO patients in aircrafts or in ambulances, and treated soon up to 800-900 ECMO patients. So I'm one of the ECMO nerds there in that center. I don't know anything else. I know how to ski too. So any conflicts of interest? No. I wish I had. And this is the new famous hospital that Karolinska have moved into. You see this, it's not the fancy white black stripe thing, it's the white thing in the behind. The ECMO unit is behind the hotel, so we don't have the view anymore. And as you see, the streets are empty in Sweden and in Stockholm in particular. When it comes to cardiac arrest, ECPR thing, I think the Swedish way we're trying to set it up with the cardiac arrest at home and stuff is to bring them to the hospital as soon as possible, because the streets are quite free of people. It's just 9-10 million people in a country bigger than Germany. So, this unit of ours, 4 to 6 bed, 90 patients per year, so far more than 1,200, and I just checked yesterday and we've done 925 retrievals so far. And it's 50-50 children, adults. We cover the Scandinavian area and Ireland. And as you see, non-cardiac patients are the ones we treat. If they have an arrest coming into the ER, they call us, we go down, we cannulate. Magnus, who is here, I'm going to talk about trauma. Cannulates, I fix with a machine. We bring them to the thoracic ICU who owns the patient. So that's where they end up. And this is where we've been flying around. The longest way was down to Perth, actually, with a patient. Iceland we go now and then. Finland very often. The most horrible transport I ever had was from Spain and back. Had to make a pop by in Lyon and get the cannulas refixed because the patient bled out 10 liters or something. And I got all this gray hair. The woman survived. So to an ECMO center like this, and to be on ECMO apart from the cardiac arrest patients that you heard about, who is welcome there? Well, let's take this again and think of it. It's everybody who suffers from a life-threatening but potentially reversible conditions where cardiac respiratory support can be bridged them to safety. But will ECMO cure anything? No, it won't. But it buys time. And this is the real time machine. I used to tell my friends that I work at a place where we have a time machine. We buy time for patients to heal. So if we can apply this without killing the patient, and we don't cause harm to the staff by something, yeah, you know. And then you hear a patient be on for 600 and something days on ECMO. So tomorrow ECMO might not be just for acute events, but someone will come up and say, you know, I have this chronic thing and I heard about someone being on for 600 and something days. I also want 1.5 years on the ECMO machine being awake. Put me on. This will come and this will cost. So, I just want to bring to you a couple of patient types that you might consider, no, they're never going to have ECMO. The ones who's been on a ventilator with high FiO2 for longer than a week. They said like, oh no, they can't do. Because in the beginning, this is a picture from the 80s actually, and when it was brought to me, I was blown away because I thought, why didn't anyone tell me before? Here is day 0, there's day 7, here's 100% of whatever is going to happen. Edema, and then more and more. If these are the lungs, here you have swine flu or sepsis. First your lungs leak and you give fluids. And in Sweden we don't give whole blood, we give crystalloids. So the lungs turns into wet sponges, and if they are damaged enough, the patient tries to die. And if they call us fast enough, we can put them on ECMO and they might survive. And if you kill the bug, these resolve quickly. But if the inflammation is really, really severe, and then that's the wet sponge lung. But if they go all the way to a consolidated block of, it looks like pudding. If you put that patient on ECMO, that'll take a month before that lung will heal and recover, be soft again. And everybody who don't want to wait a month, I mean a cardiac arrest patient in ICU blocks a bed for days. This is weeks, maybe months. You can think of how people think about that. And with the mental state that me and you and us carries, that, you know, want things to happen now, not in a month from now. But these patients do heal if they're called upon, and could they have ECMO, put them on. And the septic shock patients, people might say that septic shock, you know, can't do with ECMO, vasoplegia, anything. This is data we put together from 3 consecutive years. It's about to be published and by a colleague of mine. And the survival rates are immense. And the patients were sick as stink when they were put on. They were, you know, industrial doses of inotropes, all of them. And considered to be like, they're going to die. So maybe we try ECMO. But, you know, contraindications, basically Ebola. And I can see that. I would be, you know, well, maybe not. And widespread cancer, pure need for palliation. Our unit don't do palliation at the age. I'll put on a guy who I see climb Matterhorn here if he's 70 years old, but decline someone my age with, you know, diabetic since whenever and now his 3rd kidney transplant and aspergillus in his blood and immune suppressive, you know, that physiology was due date 20 years ago. So Age is a number. You need to look at sort of biology age. If they call us on a patient that we will bring and pick up, it's all pre-packed. This is the small machine. You remember a Pixar movie with a small thing that carried garbage on an abandoned planet? It looks like that. This is the heater. Very important thing to keep the patient warm. It is packed pre-neoped adult stuff. Cannulas, you pick whatever cannulas you need. Is this concept of transporting and picking up patients new? Not at all. It's been around for a long time. We're just a fortunate place where we have a setup where we can do this. We can be called, and within an hour we can be on our way. The team that goes out is like Magnus, who will be cannulating the patient, me, the ECMO physician, the ICU doc, my ICU nurse, here called ECMO specialist, and if we're lucky, we bring a scrub nurse to Magnus, and there's always a training doctor. And before we take off, you know, there's a lot of calling to set up the transport. You pack the stuff, and within 1 hour, you hope. And most often, we're off to the airport, and somehow, as you know, all these things, they don't happen 8:30 in the morning. They never do. They always happen in the evening, and then you're gone, and then you work the whole night. And we used to love this one. We had an ambulance that fit into Hercules, and we can fly to Ireland or northern Finland and wherever. And then the armed forces said, like, you know, it's new government, and they said we need to earn money, so we tripled the price. Sorry, we can fly with a luxurious jet plane for what you charge us now, so fortunately. The patient, the hospital, referring hospital, we have contact with them, of course, while on our way down there. We need blood and plasma. Should be whole blood. Diathermia, blood samples, echo machine. You know, on our homepage we have a list that they can check out, and this is sort of often the most vital thing. If we land there, we need to make sure they pick us up. And if they can put a center line on the neck and an arc line in one of the dorsalis pedis on the feet, that'd be a bonus. Then Magnus can put a guide wire here, and when he's cannulating the artery in the groin, we can keep a blood pressure check on the foot and see how much are we blocking here. And if he's blocking completely, we can just connect down there, and the leg will survive if there's anything problematic for Magnus to put the distal line. Stuff is packed. You go there, you see bedside. You discuss with the physician, you still want to go on ECMO? Is the patient trying to die right now, so we need to jump on ECMO? Or can we optimize a little and wait, or just have some coffee and talk a little, and we'll see what we do? Okay, we go for ECMO, VV or VA. And I'll now spend some minutes on the physiological aspects on, you know, the ECMO machine is a really simple, it just pumps blood. A normal ventilator is in a different universe when it comes to how many man-hours of great thinking went down to that machine. But what the ECMO pump can do is cause unlimited variability of physiology in that patient, depending on the situation. And that's the challenge for us as physicians, to know what to do, where to put the cannulas. Okay, what's happening now? And not just accept that a VV patient dies from right heart failure and it's noted in the paper says, oh, the patient died from multi-organ failure. That's not okay. So we go for the VV. You get a good gas exchange, and like Zach said, with a asthma patient, we have a lot of experience with patients from, you know, airways that are blocked off from tumors. They need to work on. There are peanuts down. There have been barotraumas. It's, you know, put them on VV ECMO. You know, you can do whatever you want as long, you know, forever in the airway, no problem. And we've also seen that the PVR goes down a little, so you get a little better feeling on the left side. The circulation stabilizes. We don't really know why. The VA, you know, you get your DO2. And for my friends from medical school, I used to say I'm in the DO2 business. So I'm so happy to hear more people here have talked about the DO2 sort of, because that's really what we do. And so VV or VA, if you don't choose, you'll end up on the tree, and that's not good. So what we do more or less always, you get that echo machine. Next, after the ECMO machine, that's my second favorite, I must say. And if the heart is okay, of course, go VV. If you have a big global failing heart, go VA. But also make a risk assessment, because if you're going to fly this patient from Ireland to Stockholm, I'll be out of hospital reach for 6 hours on the road. And if I put someone on VV, and that heart decides to stun over the Nordic Sea, I'm not going to be very happy, and the patient will be very dead before I get home. So, you know, don't be heroic there and do VV just because of. Then you do VA, and this is how they look down very often. The VV, pictures like this, some of you have seen before. Either you pump with 2 cannulas, or you have a double lumen here. And on the babies and the ones less than 12 kilos, we need to go on the neck, because, you know, the vessels in the groins just aren't that big. Because a baby, when the baby is born, if you think of it, it's a nervous system with a gas exchange device, a pump to do the DO2 thing, and some organs to extract nutrients. And from there on you go, and after a year, this baby, now you have extremities, and now there are blood vessels. This is a pretty picture. You suck in the IVC and the SVC, and you give back in the right atrium. And then, unfortunately, the diaphragm start to move. This ends up in the liver, and you get this flush somewhere else, and you get recirculation, and you need to reposition the cannula. So, failing circulation, well, go VA. If you're in doubt, then arterial. And this is very often how this is on their homepage. And it sucks, and it brings back, and this will not work because it will collapse the IVC eventually. And if you connect here, make sure you have a distal cannulation so you save this leg. And when you're going transporting this patient, check the temperature of the leg, because once you wrap the patient there, you might think that, okay, now we look at the other things. You come home, there were 4 or 5 hours of a cold leg. Now you have compartment there, and you need to cut it open and stuff. And the vasopressors, often you can wean them off, almost all of them, but definitely not in every patient. We don't know why. And this is how you might need to cannulate a patient that have been living all his life in a wheelchair and basically didn't have any arteries worth cannulating in the groins. And that can be an unpleasant surprise. And we have this, you know, sometimes it's called Harlequin, north-south, whatever you like, syndrome, where when you pump VA and you use the groin, if you suck out here in the IVC and you give back retrogradely up here, the black blood coming in the SVC will go up, fill the aortic arch, and you get a blue head. And people have been thinking about this. And for the VV, I might end up in the same. But if you just remember one thing from here is, if you ever end up in a situation where you need to have a venous cannula into a patient with lungs that doesn't work, you need to chase the most desaturated blood, and you need to avoid desaturated blood recirculation up here. You basically need to empty SVC. That you do by a cannula from here, multi-stage, and then if you need more flow, the tip of it sits in the atrium, and you get the rest of whatever liters per minute you need. If you do that, you will not need to do any of the other fancy cannulation. If you put in a multi-stage in the groin like this, these holes will drain almost all of the blood. And if you have filled the aorta with well-saturated blood that went down, made your lower body pink, then came up here, it will come out here. And if you have a SAT in your machine of 85, you just have 15% left on that hemoglobin to add new oxygen. So you will not be very efficient. The goals with the venous cannula will be you need to have a good way to drain, and I'd say if you put it in the right atrium and you suck the side holes in the SVC, that'll be good. If you do pumping the other way around, some studies show that, but if you look into those studies, where did they position their cannulas? You will see that black blood from the SVC actually recirculated to the head. That's why you end up with poor saturation in your head. I love that. We come back to it. And on ECMO patients, you will find that sometimes the SVO2 that you get from the machine, sometimes it's high, and sometimes it's low, and it can be both. If it goes up, it can be good because the patient's lungs might be recovering and you pump less, or it can be bad because you're having more recirculation, so you need to do something about it. Or if it goes down, it could be good because the patient is starting to extract more oxygen and anabolism is starting and healing is there. Could be bad because you're not delivering as much oxygen as you did before. So you lost some hemoglobin somewhere? Have you lost pump flow? What's happening there? So what we're used to when we take our central line blood gas and analyze it, in an ECMO patient, it can be the opposite of what you would expect. VVA or VAV, you know, VVA, you might have one cannula here, one in the groin draining, and you put into the femoral artery. If you have problems with putting the cannulas in here, that's how you might end up needing to drain. But that sometimes ends up with a VAV. Some of you might not have heard it, but it's like you drain from the cava superior, but then you have a blue head, and you think like, maybe we put some of the machine blood back to get more saturated venous blood to the head, so you don't have a blue brain and a pink lower body. That's just a sign of you not having your venous cannula in the proper position. If you put in a multi-stage cannula at the neck, you drain the SVC, you will break the vicious circle of blue blood to the head, and you will not have to put in that extra cannula, causing a lot of problems, because if you divert the blood from the machine to different tubings, sometimes you need to clamp them, you cause clotting, and it's not good. This cannula, put it on the neck, you will have no more problems. So, that was about physiology. Cannulation, yeah, I think those hands are magnets actually. There are huge cannulas, as you know, that need to be put in. And if you have a problem with the distal one, make sure you have arteria dorsalis pedis, because the leg will be alive. Take home there. You pick the patient that have a potential of healing. Drain where you have the most desaturated blood, right atrium and SVC. Stop the vicious circle of desaturated blood going to the brain. Think DO2, not saturation. And everybody can start ECMO, but you need a nice plan to end it well. And when you put in your cannulas there, ultrasound is beautiful to see. You do a chest x-ray, you see cannula tip in the vein too high up. Push it down. Do you see a lot of air in those lungs? No. ECMO is needed, otherwise it stays. And here, you have it on the neck. And now, the patient is cannulated. I got a little more than 2 minutes left to go home. And you have to check your cannulas. You need to have enough blood and plasma. Triple check that you ride the ambulance, the plane, everything. It's there, it's okay. There are no loose ends there. And like some other speakers said, have a plan and be ready to improvise. That could go for, I don't think I've had one retrieval of a patient that went according to plan over 11 years. It's always been something, you know. Suddenly there's a snowstorm and the stopcocks, they just freeze. And those tubes, and then you say, you know, we'd like, can you please open a hangar so we can be indoors? And they just say, no, we don't want to. but this is patient life and death and blah, blah. No, they won't. And then you get up in your plane and things seems very nice. And then this is what it looks like inside there. And here you see human liver for transplantation. ECMO patient, how did that? Well, we put on a patient in Finland, and then they called and said, we need your plane. Sorry, we need it too, because we need to put this patient on. They said, we have a liver in Finland that can be brought to Sweden immediately. Can you pick it up on the way? Well, what the hell? So we sat down the plane, opened the door, they threw the bag in, and we took off again. And when we landed in Stockholm, they were standing there waiting, and we just opened the door, and the liver went off. So you need to think outside that box and improvise. During the trip, check the leg and take your venous gases to see if you need to do something. Every time you moved your patient between different settings, check the electricity, sweep gut, heat, and do you have your flows in your pump. And this is how things look. And basically, we fly and move with only need of electricity and oxygen. And sometimes we do very strange transports. This woman was waiting for a lung transplant, and she was starting to mentally feel, So we took her home. We took her for a ride over a day, and she could have her ECMO and a fika, which is in Swedish a coffee, and so with her, neighbor. And then she lasted another 2 months in our unit. This was the woman I brought home from Spain who got a lung transplant, and after 9 months, she went home. She's now cruising Europe in a caravan with her husband. And this is, if you ever get to run ECMO machines, after you take the patient off, flush them with just the tap water backwards and look into the system, and you will discover interesting stuff. It's really nasty. And if you want to become an ECMO center, well, you need to avoid complications, because this is a method that seems easy to run, but it can cause havoc if you don't run it right. And your hospital officials there will be, fortunately in Sweden they are not as bad. They're being busy with other stuff than being on my back. But I can easily see the same thing come here. And in short, we like to be able to pump the most desaturated blood out. We keep our patients crisp. We like big, short cannulas for obvious reasons. We like the draining tip in the atrium. We accept saturations down to 70% unless there's lactic acidosis or something. So you need hemoglobin, of course. And if patients' heart conditions start to show sign of right-sided heart failure on VV ECMO after a week or two, we convert to VA. And I need to say that we also don't have any problems with obese patients, as some of you have seen, because the bigger they are, the quicker they get off ECMO, which is really, and we think it's because they can't take a lot of stress, because then they're trying to die, and then they bring up a short way by ECMO, and then they're good again. And this is how a Christmas tree looks at an ECMO unit. I came on Christmas Day morning, and I was like, what? You see the gloves that have been inflated here, and this is how the staff is. And I also do like to keep, and Luciano Gattinoni, all of you who do ICU and anesthesia, and this is what he said when I met him a couple of times, and I'm a strong believer in clinical experience and anecdotes, but I don't believe in mortality. You just extend the x-axis and we'll all be dead. And he said a lot of other crazy stuff too. Go on ECMO, be happy, and this is our app if you want it on your iPhone. You just email me and I'll put your name there and you cut it in the how you like it. Good. I think I'm done there. If you have any questions, I'll be with a cheese fondue and all that stuff.
Okay, thank you very much, Håkan. That was great. We'll have a break in this ECMO session now. half an hour. During the break, we will play a little film here made by Marius. He'll do a short introduction. He'll you might have seen him walk around and film stuff. It's a great little movie. We've been fortunate with great weather. I've been praying every evening for a month now, so that seems to have worked. So, what time is it now? 1840. So we'll be back here at 1910. We'll go straight to the fondue after the sessions here are finished. So if you need to change or anything, this is a good time to do it. Oliver, do you have some?
Yeah, we changed. Is it working? We changed the plan a little bit. So if anybody is interested about helicopter presentation, new helicopters we will bring soon, please stay here in the room. We do it a little bit more individually, that I can answer to individual questions if you like. So anybody interested in helicopter, stay after the break in the room.
Okay, so that's great. Even more, we've had some great flights with helicopters, so you can get even more info after the session's finished and just before the fondue. But now over to a little movie, and we'll have a break, and you can get something to drink and all that. And we'll see you here in not more than half an hour. We have a tight program. Okay.
Hi everyone. First I want to say I'm really happy being here. It's so admirable to see what you're doing. I'm not a doctor. I'm here with Marie, with Miku, for actually helping her making a video that we have been doing with Air Samad, with Patrick and Oliver, that have been fantastic to see how they operate. But then I got the idea, why not make a little video for the conference here when I'm anyways here. So this video is from yesterday, from day one, and yeah. Do you think we can, Patrick, can you see if we can turn down the light? Is it one of the, is it up here? Could be nice. Ready?
Big Sick off! No! No!
Okay, please take your seats. Sorry, the guy standing over there, he's the American with the helicopter. With the mobile? Yes. Yeah, with the pink, like in the back there. Okay. What you're trying to do. Okay, then we're starting up with the last of the ECMO talks. It's on ECMO for trauma patients. It was briefly mentioned by a guest on this yesterday. We've been lucky to do a few cases. You'll tell us a bit more about how you do it and on your research. I'm really looking forward to this talk. So thank you, Magnus Larsson.
Thank you. Can you hear me in the back? Okay, good. Thank you. Well, first of all, thank you very much for inviting us here. It's been a wonderful conference so far. Special thanks to all you guys organizing it, of course. Thomas, Mats, Pia Maria, Daniel, etc. So I'm going to talk about ECMO in trauma, and the ECMO in trauma is in some way a bit new, but there's also history back. So we will get further into this. Warfare is probably the only thing that benefits medicine benefits of. So the warfare during the wars, the great wars, a lot of knowledge about surgery has developed. And in these situations, a long time ago, the surgeons just needed to do something. They didn't have the knowledge, they didn't have the skills, but they realized that we have to do something to save the life of this patient. There was a battle in Lund in December 1676. In those days we had German and Swiss barber surgeons, Feldskärare, and they were actually only 4 persons per 1,200 soldiers. So you can imagine that the healthcare system wasn't really that developed in those days. Nevertheless, in this day, the 4th of December, more than 9,000 men were slaughtered on the fields outside of Lund. And, well, you can imagine they just had to start to develop ways of treating the patients, pouring boiling water to the amputated legs, opening the thorax for bleedings, etc., etc. And in some way, of course, we have gone a lot forward since then, but there are still patients that we cannot salvage with normal methods, and we need to cope with this and to have new strategies. So this is what I would like to talk about now. And our late King Sigismund, he had on his deathbed, he said, "Contra vi mortis non est medicamen," which means there is no cure for the lethal power of death. But I hope I can show you that there is a cure for the lethal power of death. So, nothing is new under the sun, and as always, the Americans are first, right? Where is Zach? Somewhere, yeah. Was a guy or a thoracic surgeon in 1972, Dr. J.D. Hill. Got a patient after a motorbike accident with an aortic dissection, and he put this patient on a bypass for the surgery, and after a couple of days this patient developed the ARDS, adult respiratory distress syndrome, as you all know. And the patient was on 75 hours of treatment, and the patient actually survived. And this counts for actually the first trauma patient on ECMO, as we know, and also actually one of the first ECMO cases that were ever performed. Håkan talked a little bit about the history as well, but when they put the ECMO, the bypass machine from the operating theater into the ICU, that's what this is all about. So, this is not so controversial nowadays. A lot of centers are having ECMO units connected to the trauma units. And there was a recent review from last year where they had 12 studies, altogether 215 patients. There was a survival rate of 50 to 79%, and the bleeding-related mortality was 0 to 38%. But after 1995, the bleeding-related mortality went down, and I'm going to get further into this. A lot of the patients died out of sepsis and multi-system organ failure, of course. The trend for the treatment nowadays is that we don't need heparin. We don't use heparin the first 24 to 48 hours. So if the trauma surgeons at your home hospital are complaining about ECMO and heparin, forget about the heparin. It's not needed. And the majority of these patients were ARDS patients, of course. But nevertheless, author stated that the use of ECLS in trauma patients, when needed, survival benefits that significantly overweigh the feared risk of eating. So I think this is not so. What are we going to talk about now? Well, this is something more controversial. This is something where we are actually in the off-piste country of medicine. We don't have studies to support all our data. We just sometimes need to do what needs to be done because we have nothing else to do. The patient is dying in front of us and we need to do something about it. These are exclusive multi-trauma patients. Of course, normal trauma patients will be taken care of, as always, with damage control resuscitation, damage control control surgery, etc. But these patients are the ones that we think about, you know, the patients on the slippery slope, the patients that have caught the lethal triad of coagulopathy, and there's nothing else working. But still, if you read the ELSO guidelines, where all these ECMO indications criteria are stated, there is not an acceptance for these patient groups. I need to say this because what we will talk about now is something a bit further. And as I understand, this conference is a little bit about going further, the next step. What can we do? And how many of you are anesthesiologists or intensivists? So the vast majority. So I hope one of you can tell me what is with this picture. What's the problem with this picture? No, it's not this. It's disconnected. There is also. No. The endotracheal tube is filled with blood. This was a construction worker, fell 7 stories from where he was at his workplace, fell down, had a bad liver injury, had a ruptured right chamber, had the bilateral laceration. When our anesthesiologist intubated the patient, there was blood just gushing out of the tube. And they realized, well, we cannot keep this patient alive on a normal ventilator. So this guy looks a bit fairly healthy, doesn't he? So we can see that he has he's okay. He's not cyanotic. And why is that? Well, of course, we are having ECMO cannulas in the neck here, and there's also 2 cannulas, one for the artery in the groin and one for the vein. So this is how we kept this guy alive. He was operated on for 8 hours and actually went with some small sequelae, but he was alive and went home afterwards. Is it working? So, and I will tell you another case that actually opened our ideas and minds about ECMO in trauma with lethal bleeding or hypovolemic shock. Not the ARDS patient, but the ones that arrive to the hospital and they are just dying in front of you. Mimi was a 12-year-old girl. She was in her parents' garden at home in the summer. She is really frightened of dogs, and the neighbor's dog ran into the garden where Mimi took off and ran out in the street. And there she gets hit by a lorry. And she had severe bleedings in her head, bilateral contusions and bleeding in the lungs, a grade 4 injury of the liver, spleen injury, pelvic fracture, bilateral femur fractures. So she was in a really bad state. And as you can see, her vital parameters were really deranged, and the pH was below 7, which is almost 100% mortality rate in the trauma patient. So during the night she was operated on. The trauma surgeon started to open the abdomen, pack the liver, try to make the Pringle maneuver, close the vena cava, etc., etc. It just continued to bleed. The pelvis was temporarily stabilized, the femur fractures were stabilized, etc. But she kept on bleeding, and the liver was the problem. So after 5 liters of packed red blood cells and fresh frozen plasma and thrombocytes, she got, of course, a trolley. So in the morning, at that summer morning, we needed to put her on. So then something really strange happened. We cannulated her for a VA ECMO, and that was the first time when the trauma surgeons can control the bleeding. And this was, of course, something that we didn't expect to happen. What actually did happen? And we had some speculations of that. The abdomen was packed. She was re-laparotomized 24 hours later, and she was weaned off ECMO 52 hours later. And she actually survived without handicap. She has just a slight problem with her right foot, but otherwise she's living by her own, she has her work, etc., and she's been studying, so she's fine today. But what happened with the bleeding? And was there mainly a venous bleeding? Might it had something to do with the venous pressure? Did we in some way correct the coagulation, or at least adjust the coagulation? And there is another case. Anna, she's 18 years old. She was a totally healthy girl, and in January night she had a fight with her boyfriend who broke up. She got drunk, and she made probably a suicide attempt. In the morning she was found between 2 train wagons, and when she came to the hospital, it was a bilateral hemothorax with drainages, an unstable pelvic fracture. She had an abdominal compartment which caused a laparotomy, massive lung bleedings, hypoxia, and she got a cardiac arrest on the trauma room. So what did we do? Well, we, as I said before, what shall you do? There is nothing else you can do, and the last resort at our hospital is the ECMO team. So they called us, and we put her on ECMO. She got 21 French cannulas in each femoral vein, and she got this 17 French artery in the right groin, and also an 8 French distal cannula. She was put on ECMO without heparin. During the care, she got almost 200 units of packed red blood cells, fresh frozen plasma, 15 units of thrombocytes, 54 liters. She also had for a while a heart stun, but we continued to treat her on the VA ECMO. There was a sudden bleeding from the right lung, so we had to do a thoracotomy and to cease the bleeding. 2 days after we had put her first on ECMO, she was converted to VV ECMO because the heart was working okay, and we always do that when we are in a situation where we can step down of the treatment to make it less dangerous. We like to do that. And after 3 days of treatment, she was off ECMO, and she actually survived without neurological deficits. Of course, all cases are not this happy. We have a lot of cases as well that has not gone this good. But in these cases, these are young, healthy persons, and it's really, really fantastic to be able to take part of that care. Very, very shortly, about that people have been talking a lot about ECMO, but just for you guys who don't work with this on a regular basis, ECMO is something really, really simple. Really simple. It's not rocket science. It's a tubings, it's a pump, it's an oxygenator, and it's a heater. That's about it. Draining blood from the right atrium to the machine, centrifugal pump pumps it further on to the oxygenator where the blood is oxygenated and carbon dioxide is removed. The blood is warmed and it goes back in 38 degrees in this line. In this case, it's a VV ECMO, giving it back on the venous side, just a lung support. If we put that red line into the carotid artery or into the femoral artery, it will be a VA ECMO, and we will be in a full bypass, and then we are supporting the heart and the lungs, of course. So, ECMO has some benefits. We can increase the saturation, we can decrease the carbon dioxide, we can increase the temperature, it stabilizes the circulation, and it gives the lungs a possibility to rest. But as Håkan said, ECMO does not treat any, doesn't heal patients, but it buys us time for other things. And it's life-saving. And it's life dangerous as well. There is a risk when you do the cannulations for bleedings. Thromboembolism is a really big challenge to avoid that. Infection and inflammation in the system, which also causes inflammation in the whole body, and we can have technical complications. So this is something we need to do because we have nothing else, but we want to get rid of the machine as fast as possible because we know that it's really dangerous to be on the machine. So when we cannulate trauma victims, we tend to do what we call a semi-percutaneous route, which we make a cut down in the groin, preferably because the anesthesiologists are working with the head and all in the upper part of the body, except for small kids, then we need the neck because they have 2 small vessels in the groin. And we use about 10 minutes per site, so it's really fast. Once you see the vessels, you make like a selling it technique when you put the CV line in. It's nothing strange. It's easy to do when you're trained. And we prefer this because these patients are almost empty of blood. We need to see the vessels. I've made mistakes a lot of times to do it percutaneously with ultrasound. It's difficult, at least for me, in an ECPR patient or in a lethally bleeding patient. So this is how it looks like. We want to put the cannula in the artery. We've seen this, Zach showed us earlier as well. And if we go for the groin, we have a very long, huge cannula that we want to have pointed all the way up to the right atrium. This is what it looks like in real life. Another article which I think is good is the one, the group in Regensburg, Matthias Ahl's group wrote this in 2010. It's really good because this is the first paper stating that you can do VA and VV ECMO in lethally bleeding patients. And as said before, we are in the situation we don't know what to do. I talked to a guy from Baltimore on another conference, ECMO conference, and we talked about he had a patient coming in where the wife had a shotgun into his chest, so there were multiple holes in the heart. And I said, how the hell did you actually perform that? Didn't you get air into the system? Didn't you hesitate? Well, what should we do? They had no alternative, and it actually went okay with it even in that situation. And if you get air in the system, there are ways to get rid of the air as well. So, but in this paper, you can read about these patients, 10 patients, all of them in bleeding shock, and they had a survival rate of 6 patients. So, if you now back to the young girl, Mimi, the 12-year-old that got hit by the lorry, we had two ideas. What might have happened when the liver ceased to bleed? Well, keep that in mind. And we thought that in the case of a trauma patient, you tend to give them a lot of liquid, right? A lot of fluid, Ringer's lactate, etc., which you shouldn't do, but still some ambulances do, and blood products at the hospital. This may increase the right ventricular load, which will, of course, make the pulmonary resistance increased and increase the central venous pressure. So, if you theoretically think that you have a hole in a vein, the bleeding from the hole will depend on the size of the hole and on the pressure inside the vessel. That's not so strange. It's like when you go watering your garden, and if there's a hole in the tube, if you have high pressure, it bleeds a lot. That's not rocket science. Everyone understands that. So we made a study with pigs, and we put them on VA ECMO. We made them have a high pressure on the right side of the heart by increasing PEEP in the respirator and giving them mannitol as well. And then we could see, apart from that, we had the mean arterial pressure that very nicely went up. We could also see, especially when we had an increased right ventricular load, that we got a decrease in the central venous pressure. So this might be one of the answers why Mimi's liver, the bleeding ceased a little. Some words about hypovolemic shock. Today, about 10,000 people every day worldwide die out of hypovolemic shock in accidents and murders, etc. And this is especially in the young group from 5 to 45 years of age. And 30% of patients who die of bleeding. So that's once you are in the hospital. Outside the hospital, CNS injuries, etc. are more common. But once you are into the hospital, so there is a need to be able to control bleedings more efficiently than we are today. And a lot of these patients are in the badly shock state, class 4, meaning more than 40% of the blood volume lost. So we are getting the last 15-20 years, we are talking about damage control surgery, damage control resuscitation, and all these things are fantastic and they make a difference, definitely. We also have this massive blood transfusion protocol. We heard yesterday about whole blood transfusion, etc. And I want to talk to you guys a little about coagulopathy. How many of you knows how coagulopathy looks and feels like? Hand up. So I don't mean ROTEM. I don't mean APTT. I don't mean INR. So when we surgeons have these patients, you can feel there is no clotting. It's not sticky. Blood is not sticky anymore. It's black, it's desaturated, it's cold, and it's not sticky anymore. And this is something that, how skillful you are as a surgeon, you still need to have your friend coagulation, otherwise things will go worse and worse. And what happens with coagulopathy is that it's about around 1/4 of all the severely injured patients that gets trauma-induced coagulopathy. It increases the mortality by 4 times. And it has to do with tissue injury and systemic hyperperfusion. We know that the platelet functions are not so good. The factor V activity is reduced. Fibrinogen levels are getting reduced really fast after the accident. And also the protein C is activated, meaning that the fibrinolysis starts. And all this is exacerbated by hypothermia and by acidosis, especially when you get below pH 7.2 or when you have a temperature below 33 degrees. So with this in mind, and still the young girl with the liver trauma, we wanted to see how does ECMO affect coagulation. We have all the time heard from the trauma community there, we're not interested in ECMO. You guys destroy coagulation. You give heparin. It's nothing that we can't use that. So we made another study with rabbits this time. 10 rabbits. We had made bilateral femur fractures on them. We bled them around 40 to 45% of the volume. They were down into hypothermia less than 32 degrees, and the pH was below 7.0. That was when we saw coagulopathy on the ROTEM curves. We knew we had to get down there. They are really, really between life and death, these animals. Of course, all of them were very deeply anesthetized. So we had 5 control rabbits, which got the normal trauma treatment, as we do at our trauma unit. They got fresh warm blood, warm blankets, etc. So everything that we would do in a normal trauma case. The other ones had the same, but also a VA ECMO on top of that. And after 60 minutes, they were in near lethal bleeding shock for 90 minutes. And after we started, we wanted to check what happens the first hour after initiation of the ECMO. And here you can see that the blood pressure was normalized first. They're around the mean arterial pressure around 60. They went down. The dotted line is the ECMO group, and the straight line is the control group. You can see there's a significant difference in between the blood pressure. We're not all the way up to where we started, but almost normalized. Temperature as well, same pattern here. and you can see that even though we gave them passive warming and warm blood, they continued to get more and more cold in the control group, whereas in the ECMO group they had a nice increase of temperature. The lactate also was significantly reduced in the ECMO group. The pH did not reach a significant value, 0.07, but it started to turn. And remember, we just gave them the treatment for 60 minutes. That was the major criticism we got from the paper when we wanted to publish this article. Why did you just go for 60 minutes? We wanted to see what happens in the trauma room. And the APTT was reduced in the ECMO. This is a very small study, so of course 5 animals in each group, so that we need to bear in mind. And we also reduced the bleeding time. We had the bleeding in the air and we had the bleeding in the cuticles, so we could reduce the bleeding with the ECMO. So it seemed like that, and even the ROTEM time was reduced, the extent clotting time, but not the stability of the clots. They were not improved, probably because the fibrinogen levels was so low and we had no possibility of giving fibrinogen to the animals. So that was some results from our studies, and I will just a couple of more pictures, and then I know my time is out. So we have 20 years of experience of traumas with ECMO, and this is from we started in 1997, and there are now 50 cases in the material. Males are, as always in trauma, more than females. Approximately the same amount of VA and VV. The bypass time on the patients has been from 1 hour to 573 hours. And if you combine these into ARDS groups and what we call the ECPR group, not all of them had cardiac arrest, but I think about half of them had, and the other ones were really into a shock state with a very, very slow heart rate, finally bradycardia in the end of the bleeding phase, and with a high ISS about 63. So we don't have so many shootings in Sweden. The majority of the traumas were traffic accidents, and as I said, the indications still, of course, are ARDS lungs. The lethally bleeding patients are few. And the results are, in the overall results, are 44% survival. In the ARDS group is 56%, and in the trauma group with the ECPR group is just 27%, which is of course not so good. And this is not published yet. We are working on the article as I speak. So what about severe trauma in the future? Well, I think that, of course, we all know PH-TLS and ATLS. That's where it all starts. The damage control resuscitation is really important. Angiography combined with damage control surgery is what we do in the hybrid operating theaters now, and this is really good to make the minimal invasive procedures. But I think there is some, in selected cases, ECMO is also something beneficial in selected patients, and this you can combine without problem when you are doing resuscitation and doing trauma surgery. And then definitive surgical trauma care, of course. So ECMO is not rocket science. It's easy and fast to cannulate. It supports the heart and lung functions. It reduces the central venous pressure, increases MAP, rewarms the patient efficiently. It fights lactate and acidosis. It may improve coagulation. We had a very small group. I know that. This is like a pilot study. You need to redo studies and check for it, but it seems like it's not at least worsening coagulopathy. And you may extend the treatment from the operating theater into the ICU, of course. You don't need heparin at all. what are the success factors? Well, you have to have a dedicated ECMO team, including a trained surgeon or someone who is really skilled in cannulating, and you need to have them fast, as Lionel was talking about. Same concept as the ECPR. You have to have the right cannulas available. You can connect it to high-speed infusion line, which you can imagine these lines, how much blood you can transfuse through them, because they are so large. Thank you. And you should be on a short bypass time. So finally, I would like to have all trauma victims coming in to have a CV line and an arterial line in the groin. And I think that's what Zach said on his lecture as well. Because if we have that in place, it's really easy and fast to cannulate. You have the option to go on ECMO. You have the option to put a REBOA. You have the option to do angiography and coiling. So, thank you.
Ja, tack. Tack Magnus Larsson, det var virkelig interessant. Jeg synes det er utrolig... Oh, why am I doing this in Norwegian? All right, that was really interesting, Magnus. I think it's a really interesting concept, both for the trauma patients, but also because it touches on so much of the physiology and corrects many of the biochemical sides of the patient, it seems. Next up, we're moving a little bit away from the ECMO now for the last talk of the evening, so hang in there. We have got Professor Tim Harris from London, who's a very well-known researcher within, well, most things ED. He's written papers on trauma, cardiac arrest, and now he's going to talk to us about fluid resuscitation in the ED. I'm very much looking forward to it. Thank you.
You know, I can hear the difference. So, unfortunately, I'm still for sale. I've got no financial declarations to declare, although I have been given some kit to play with for free. This talk deals with fluid therapy for resuscitation. We're not talking about maintenance fluids or predicting. So I'm going to start by asking you to consider what your triggers are for fluid therapy. We've had some pretty obvious cases, but you're dealing with somebody that you're going to bring into hospital for IV fluids. For IV antibiotics. Do you give them all fluids? Who do you get to drink? If their lactate's up 20%, or if their creatinine's up 20%, does that trigger you to give fluids? What if their systolic blood pressure's less than 110 when it's normally 150? What if it's 100? Taken from the Q-SOFA as a marker of severe sepsis. What if it's 90? What's your trigger? What's your target? What you're trying to achieve? So we're going to do the simple overview first. This is dedicated to pilots from EAAA, and I hope I haven't missed your talk because I'm really looking forward to it. As I suspect for most of you in the room, this is knowledge. Where's that? You two should know this. Yeah, it's St. Paul's. St. Paul's was finished in 1710. Who designed it? Yeah, what's Wren got to do with fluids? So as far as I can see, Sir Christopher Wren, an architect who redesigned a lot of London after the Great Fire, was the first person I can find that documented intravenous fluids. Around 1700, London didn't have a great reputation for water. So the intravenous fluids he used were the oral fluids that most people were taking, wine and alcohol. Didn't go well. Medicine left that for a little while, and then in the 1820s, 1830s, there was some debate in BMJ, Lancet, and Dr. William O'Shannessy described a theoretical framework for fluids. That was picked up by a Scottish GP called Thomas Latter, who went to see a woman in a croft, a wee farm, who was dying of cholera. She was unconscious, she had no radial pulse, and he said, she's going to die. I may as well try this intravenous fluid. And as I'm sure many of you know, in her kitchen he mixed up a solution, a little similar to Ringer's or Hartmann's, delivered it into a vein, she recovered consciousness, he took her to a hospital, he handed her to a surgeon who stopped the fluid, and she died. Not a great success story, but a start. And of course, this precluded, there were no plastics, there was no germ theory, we had no way of sterilizing skin. But over the next 50 years, animal models taught us that hypovolemic shock was fluid loss, not red cell loss. Saline was described based on a wrong calculation, and of course it's still 0.9% saline today, a couple of hundred years later. And by 1890, intravenous fluid as a therapy was being taught in most UK medical schools. So it's been a really good decade for knowledge of fluids. If we look at coming into this century, the popularity of starches, the debate of albumin, we've now largely solved most of those, and most of us would not use starches, and certainly not for sepsis, and most of us would bring our choice resuscitation fluid as crystalloids. It's worth just remembering that the reason we have problems with fluids and why we can't just mimic human fluid is bicarbonate. We can't really store bicarbonate for any length of time in plastic. So the fluids we use substitute bicarbonate with something else, lactate, chloride, or acetate gluconate. Chloride is associated with reduced renal blood flow, and lots of cohort studies suggest that there is an associated renal injury. There was a well-conducted randomized trial by Paul Young and colleagues in New Zealand, which I'm sure most of you are familiar with, which suggested that in his 2,278 patients, the use of saline as compared to balanced solutions didn't increase acute kidney injury, renal replacement therapy, or mortality. Thing is, that trial's arguably underpowered. If you think of the volume of patients going through hospital that get IV fluids, even a very small benefit was going to translate to a lot of patient survival. Now, as far as I'm aware, this is not published. There's two large trials, one based on ED fluids and this one based on ICU fluids. It's a Canadian trial, just shy of 16,000 patients, and it's been released in abstract form, and I'm sure many of you have read this too. But this compares normal saline to either Ringer's or Plasmolite, and their composite endpoint of death, new renal replacement, or doubling the creatinine did show a significant difference in favour of balanced solutions as compared to saline. It's hard to know, hard to comment about this until we've read the paper, but it's interesting because we're getting a signal that the cohort studies suggested for us. Much harder is how much fluid we're going to give and what we're trying to achieve. Many doctors in pre-hospital care and emergency rely on simple physiology to risk assess patients, to identify shock and to guide their resuscitation. The problem is the final act of homeostasis of mammals is to defend blood pressure, and this means until you've lost a third of your circulating volume, the relationship between cardiac output and blood pressure is non-linear, only becomes linear as you enter the stage of dying. And so if you use blood pressure and pulse to guide your fluid resuscitation, you may normalize them but leave your patients under-resuscitated. So what goals are we going to use? And the idea of goal-directed therapy, of titrating fluids against some measure of oxygen delivery, cardiac output or stroke volume, is a much debated issue. We've got some trials suggesting benefit and other large trials suggesting no benefit. So where is this in the ED? So we've had 5 large sepsis trials that looked at the goals of blood pressure, CVP and saturation, the Rivers protocol, as compared to various aspects of so-called usual care, physician-directed care. The 3 large trials, Process, Arise and Promise, suggested to us that goal-directed therapy increases the volume of fluid, the amount of cells and presses, costs and ICU care. And of course, that didn't translate into any improvement in mortality. So is this the end of goal-directed therapy as part of emergency resuscitation? I don't think so. These trials didn't assess optimum fluid load. They didn't really look at stroke volume responsiveness. And the targets of SCVO2, well, if you look at their data, they don't tell you how many patients actually had an abnormal SCVO2. And I've written to the authors, I only heard back from 2 of them, but they said it was under 1 in 20. And that suggests that SCVO2 is really not a great target for us to pick in the ED because it's abnormal in such a small proportion of patients. And that also sees these trials underpowered. And we know that static markers of preload, be it wedge pressure or CVP, are really not useful guides to fluid therapy or fluid responsiveness. So can fluids harm? Does it actually matter? Because they're cheap, it's not a cost issue. I think trial of the decade is Kath Maitland's study, predominantly in Kenya, randomizing children with severe sepsis by a set of clinical criteria to have either a bolus of albumin saline, a bolus of saline, or no bolus. This trial was conducted because at the time in Europe we were promoting bolus therapy as a pancreas of sepsis care. And in Africa that was a real problem because they struggled to have the resources to have enough nurses to safely give bolus therapy. So their standard of care was 24 hours, 48 hours of fluid at a set rate. And I think many of us were surprised to see the absolute increase in mortality of around 3% associated with the fluid bolus. And the FISH trial, which is a UK trial to try and answer this question, has finished recruiting but is not yet published. Some months ago, a much smaller but very well conducted randomized trial in Zambia was published in JAMA. So these authors took 212 patients and randomized them to physician-directed care or protocol care. The protocol care was to give 2 litres within the first hour and then another 2 litres in the next up to 6 hours. After each litre of fluid, the patients were assessed clinically for signs of overload, looking at their JVP, looking at their respiratory rate, looking at their saturations. And fluids were given until there was a suggestion of fluid overload. They could also give red cells with the trigger of 7 and use dopamine to achieve a MAP over 65. And this trial showed quite a marked mortality benefit in favour of physician care. And I think this trial is interesting because unlike Process, Arise and Promise, the volume of fluids given in the protocol group versus the usual care group was significantly different by 1.5 litres in that first 6-hour period. Now most of you work intensive care and will therefore be very familiar with the dangers of tissue edema, compartment syndromes and the reduction in oxygen delivery at a cellular level consequent about fluid overloading. So we're stuck with a dilemma. We need to give our patients sufficient fluid to optimize the stroke volume and cardiac output for their needs and match to their requirements, but we don't want to create Michelin Man. We don't want to create edematous people because that tissue edema reduces oxygenation. So in the UK, NICE suggests that we deliver fluid as a 500 ml bolus over 15 to 30 minutes. We assess for clinical signs of overload, and ideally we measure cardiac output and we define fluid responders as those that have a greater than 10 to 15% increase in their stroke volume. And I think those are the figures that many of you will use in practice. And while there's no generalized agreement, certainly the majority of trials use some similar figures. And our problem, of course, is we really don't know where our patients are on Starling's curve. We don't know where we are on the curve itself or how our curve will be, how our hearts will respond to volume loading. We're not sure if they're hyperadrenergic or they've got a chronic cardiac condition or an acute cardiac condition such as sepsis-induced cardiomyopathy. And as we get to the top of Starling's curve, the risk-benefit shifts, and we can see a rapid increase in extravascular lung water and tissue edema. So in ICU, we can measure cardiac output quite easily. It's a little harder in the ED. We can certainly use echo. We can look for a very active, healthy-looking heart that we would expect to respond well to a fluid loading. We can look for a heart with moderate or severe dysfunction that we would expect to do badly, that we would want to look at other measures such as catecholamines for their resuscitation. But that doesn't tell us where they are, because even that bad heart may well respond to some fluid. So let's have a look at the physiological effects of a fluid bolus. And you know, given that fluid bolus is the basic tenet of resuscitation, we know remarkably little about it. This is an Australian group, and this is their meta-analysis of 33 papers published within around 5 years of this paper being put out in 2014. And they noted that different physicians use very different fluid boluses, and that they noted that physicians gave them over different rates and measured the response to a fluid bolus at different times. Some immediately afterwards, some 10 minutes afterwards, some then continued to measure at 30, 60 or 120 minutes. And pooling the data and just looking at mean figures, they showed that if you measured cardiac output in the first 10 minutes after the bolus, it improved nicely, 800 mils in this pooled group. There were small effects on blood pressure, 7 millimeters of mercury, and a small reduction in pulse. But if you looked at 30 or 60 minutes, those effects were largely halved. And I argue whether a 3 millimeter improvement in systolic pressure is really clinically meaningful. And this, of course, is because fluid redistributes and we adapt. So invariably, a fluid challenge risks fluid overload with all the issues that we described. I also know from this paper and many others that only around half the patients we admit to intensive care are actually fluid responders. The others need alternative support for their circulation. So what about the emergency department? Well, this is almost a data-free zone. I only found one paper, it was an observational study from Adelaide, where the authors looked at 500 patients and looked at the fluid bolus. And they too noticed that different physicians gave different volumes over different rates. There's very little standardization. The commonest reason to give a fluid bolus was hypotension. And they found quite similar to the Belomo paper. So if you measured the map after 10 minutes, it had increased significantly, but I'm not sure that's a particularly important clinical change. Heart rate had come down a bit. If you then looked at 1 hour and 2 hours, actually you'd lost the benefit that those fluids had given you for pulse and blood pressure. All you'd managed to do was significantly cool your patients and increase their respiratory rate. Certainly not the aim of fluid bolus therapy. And if you teased out those patients with shock and then teased out the patients with septic shock, you got a similar effect. The map and the heart rate were changed really by very small amounts and were normalizing out by 1 or 2 hours, suggesting the fluid boluses were not achieving the goals that the physicians wanted. And while we've only got a little data, we know that as patients come into the ED, somewhere between 1/3 and 2/3 of them are fluid responders, perhaps not so different from intensive care. And I think that's a surprise, because if you survey physicians, this is a New Zealand paper that surveyed intensivists and emergency physicians and asked them, what do you expect this bolus of fluid is going to do to your patient? You can see that 1/3 of intensivists and nearly half of emergency physicians expected a 500 ml fluid bolus to increase systolic pressure by between 10 and 20 millimeters of mercury. So it would appear we expect far more of fluids than the evidence suggests they deliver in terms of improving physiology. This interested me, so we got a group of unhealthy volunteers, medical students, and we've measured their cardiac output pre and post passive leg raising. And we found exactly the same thing. Around half of them had no response to a passive leg raise, and we were measuring their cardiac output using Cheetah and using echo VTI and using carotid Doppler. So we tried 3 different methods, and they gave us consistent data. So that raises the question, we're brought up on the Frank Starling relationship of the heart, that we should be fluid responders. I think if we take a step back and we remember what Guyton actually wrote, Guyton said the circulation is driven by tissue needs. And if we don't have tissue needs, giving fluids may not increase cardiac output and stroke volume. So, and I think we need to ask ourselves whether this actually applies under all conditions. Because tonight we're going to drink beer, some of us will drink water, and actually the organ that's going to get stimulated by that fluid load is the kidneys, not the heart. So is there any benefit from measuring stroke volume in the ED? Is there any evidence that it will actually improve patient care? This is a systematic review by Tim Coates and his colleagues from Leicester in the UK. They could only find 8 studies that explored this and only 2 randomized trials. They too noted that fluid boluses were given in very different volumes over very different time periods, and there were under 500 patients combined in all these studies. And they too noted that only 1/3 to 2/3 were fluid responders. Now, no study showed a patient-centered benefit, but there's only 500 patients in all the studies, so actually that's not a surprise. We can't answer that question. So in the emergency department, can we predict who's a fluid responder? Well, we know static measures are no good, and around 10 years ago a meta-analysis suggested that heart-lung interactions were a good way of predicting, so we could look at pulse pressure variation, stroke volume variation. But actually, those subjects were drawn from very tight control groups. And actually, I'm not sure we can apply that data in intensive care, and I'm very sure we cannot apply that data in the emergency department. If we want to know whether our ED patients are fluid responders, then there's only 2 ways I think it'll work. Give them a bolus of fluid and measure before and after, or use a PLR, which I'm sure many of you are doing. Although I must say, I struggle with the PLR. The nurses think I'm mad, and nobody comes to help me do it. It's very hard to do it by yourself. How do we assess stroke volume and cardiac output in the ED? So there's a myriad of devices. There's the OSCOM device using continuous wave Dopplers, similar to any other ultrasound. We can use bioreactants, we can use bioimpedance, we can use plasmography. These are all expensive machines. Easiest is for us to just use our phased array probe and measure the volume of blood leaving the aorta, mapping out the velocity time integer. And data from a number of studies suggest that we can achieve that in the ED setting somewhere between 70 and 90% of the time. Now, we're brought up that stroke volume measurement is useful to optimize our patients. I actually think we need to turn this on its head. I think stroke volume assessment and fluid responsiveness are most useful to identify the patients who will not benefit from fluids and will protect them from harm. Because certainly when we audit RED fluid use, we see fluids are given near universally, and certainly in sepsis in the 20 mils per kilogram or more, regardless of what's known and with few measurements. I think I'd just like to end by saying I still think we're looking at the wrong goal. Because actually, we're not giving fluids to increase stroke volume. We're giving fluids to improve tissue perfusion and tissue oxygenation. And we're slowly learning to measure this. I'm not aware of a device that's useful in the clinical arena. This is side-stream dark field imagery developed in Holland, which I'm sure many of you here have used, and it's a great research tool. It's very difficult technically to use, and your patients need to be intubated, ventilated and paralysed to stop movement artefacts as you look under their tongue. Again, that doesn't really apply to most of the patients I deal with. So in summary, we've learnt a lot about fluids this century. I think we should be giving balanced solutions, and I look forward to SMART and the ED SMART being published. I think at the moment, we know that many of our patients are not going to respond to fluids, and that measuring stroke volume is perhaps the only way that we're going to find out that group that we need to escalate to intensive care rapidly and look at alternative therapies. I don't know if goal-directed therapy has a place in the ED, and I'm not sure if stroke volume is the right goal. So I'd like to thank you for your time, and I think we're going to eat some fondue. I'm not actually quite sure what fondue is, so I'm going to need a lesson. But I'm quite scared because I've got a white shirt on and it sounds messy. So thank you for your time.
Thank you. That was a very good ending of the session, going through fluid resuscitation. And like many of the ECMO talks said, one way to avoid ECMO is to not overload on fluids. So
yeah, we've created a disease.
Eye on that. Look forward to seeing you and all the others up at the fondue night. Before you leave, like the Airbus guy Stefan said, he would love to give some info on helicopters they have and the new developments they have for any people who have a great interest in helicopters. Please stay on here, come up to the stage here, and we'll arrange